No.
Great. So now you can see my screen?
Yes, sure. It's okay.
Awesome. Okay. So hello, everyone. First of all, before introducing myself or doing anything, I'd like each and every one of you to drop an emoji in the chat bar here. Choose any emoji that you want and just drop it. If you can hear me correctly, drop any emoji in the chat.
Yeah, I can hear you. Can you
Great.
hear participants?
If you
I
can
think
hear
it's
me,
okay.
drop an emoji in the chat. Awesome.
Here is
Sila, or Sia, I guess. Merit, Rahma, hey Rahma. Berkay, hey. Oh, that's a lot. I lost count. Gamzi, hello everyone.
Everyone's very
Ella,
excited.
Merv, Alina, Yusuf. Awesome. Great. Thank you, everyone. Amazing emojis here.
Thank you. Same to you.
Awesome. Okay, so first of all, my name is Ahmed. My name is Ahmed Hassan. You can just call me Hassan. I'm from IFMSA Egypt and IFMSA International Trainer, and I'm very involved in research. I'm a core member of COVID-19, MENA Research Response Team, Medical Research Group of Egypt, Global Neurosurge Collaborative, and whatever you can add. Okay, so before starting, I'd like to clarify two very important rules in our today's webinar. The first one, when you see this emoji or this COVID thingy popping inside the screen like that motion, I want everyone to unmute your microphone and say COVID-free. Because believe it or not, today is the first birthday of the freaking virus. Today, November 17th, the first COVID case was detected in Hubei, Wuhan, capital Wuhan in China, for a 55-year-old citizen. So in order to be more motivated, to have more hope for the future, for a better future, when you see this this motion of this virus thingy popping on the screen, unmute and say COVID-free. Okay? So I'm gonna count to 3. Unmute everyone now. Unmute. I'm gonna count
please,
to 3.
Guys.
Yeah.
Don't hesitate.
I'm gonna count to 3. When I say 1, 2, 3, after 3, everyone just yell COVID-free. Okay? So 1,
Are you
2,
ready?
3.
COVID-free.
Awesome. Great, everyone. Great job. Second rule is to raise hand. If you have any question, anytime, you're very welcome to answer them. Just please click on the raise hand thingy on your Zoom application or iOS, whatever, and I will stop what I'm saying and see if you have any questions to answer. Okay, so these are very important rules. Please don't forget the COVID-free part. Again, COVID-free. Okay, here we go.
COVID-free.
COVID-free.
Awesome. Okay, only 2 are awake here. Okay, so first of all, the omega-3 fatty acids and heart health. It's been presumed that omega-3 fatty acids are very useful and very helpful for your health, for your cardiac health. That's why a lot of bodybuilders, physique players, patients with heart problems, they take omega-3 fatty acids because they believe it has some benefit to them. So what if I told you that a lot of research papers published in very, very good and renowned journals say that omega-3 fatty acids have absolutely no effect on cardiac health. And another journals with very good reputation also in scientific and medical field say that omega-3 fatty acids are very good for your cardiac health. So how should we approach omega-3 fatty acids? Should we believe those who say omega-3 are very good and beneficial for your cardiac health, or the other ones? We don't know. Okay, next one. The ACE inhibitors, which are recognized as the first class of antihypertensive drugs, the ABCD, if you remember, the ACE inhibitors, the beta blockers, calcium channel blockers, etc. So ACE inhibitors, recently, around like 2 years or 1 year before, a research paper was published in the British Medical Journal, which is one of the best medical journals in the medical field. They say that ACE inhibitors can actually cause lung cancer. OMG, because ACE inhibitors are very widely used by pretty much every hypertensive patient. So how can we approach this thing? Should we stop the ACE inhibitors and die from hypertension, or take ACE inhibitor and die from cancer? That's our part today. you should be able to critically appraise each research paper and know how to interpret this paper, how to translate it into clinical practice, not just some numbers and some words written in the paper. You should have your own critical view, your own opinion on this research paper before releasing it to the general population, and have your own critical appraisal. So that's what we're actually going to learn today in today's webinar. We're going to be able to learn some 5 main keys that you can think about before reading, or actually during reading any research paper, to be able to criticize and judge on that paper. Should I do as this paper doing it clinically in my clinical practice or not? The third one is the plaquenil or the hydroxychloroquine part. It's been a kind of a thing in the COVID-19 period recently. Some people say that hydroxychloroquine is very useful, and some people say it's not. So today, our practical part, which is the most important part of our today's webinar, we're going to have a recently published paper about hydroxychloroquine and COVID-19, and you yourselves will judge whether this paper is well and high quality done to be able to take its results and do it in our clinical practice or not. That's what we're going to do today. Our question is, how are we supposed to do that? By our 5 main keys. It's going to be an algorithm that you can think of. Of course, I'm going to share with you this presentation and other main useful resources on our Facebook group in case anyone have any questions for this. This is called the DOI. If you can see these small numbers beneath each and every one of these things, the omega-3, you can see DOI. The DOI is a shortcut for digital object identifier. You can think of it some sort of an ID number for each paper. Each paper has an ID number. Whether the journal has changed, the website itself that the paper is published on has changed, or for any reason has been deleted. If you enter this DOI number in the DOI org/, again, DOI.org/ and you add this number that starts with 10 point blah, 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 it will take you directly to the paper, whatever place it is published now. So if you want to read or explore these papers, that's the DOI numbers for these papers. So today's agenda. We're going to first talk about clinical research and its changes during the pandemic period, because of course, this pandemic has to have an effect on our research practice and clinical practice. Number 2, the types of research against the current pandemic. Research is a very broad term. It has many, many types and designs. So which type should we depend on and which type should we learn during this pandemic? That's what we're going to be talking about today. Number 3, which is the most important part, is the critical appraisal part. I'm going to give you some examples of recently published papers, for example, like the hydroxychloroquine one that we see before. And we're going to practically appraise these papers and see whether we should take its result clinically applying it or not. And number 4 is appraising recent studies after we learn how to criticize them. So this is basically our agenda for today. Okay, so general steps of clinical research. We're gonna take this as a quick overview. So what is clinical research? What is research? When we say research, we mean a research idea or a research question. You observe something, you see that a drug X can treat the disease Y, for example. So you want to know, to what extent is that drug helpful for that disease? To what extent is that drug safe for this specific disease patients? So number 1, any research, any clinical research study starts with an idea or a question. After that, you want to enrich your knowledge and read more about this thing. So for example, if you see that Panadol, which is very famous for headache, you see that Panadol is very good for headache. So I want to know more about that Panadol. So I read the research paper that recently published online, which is called the literature. And literature here doesn't mean like Shakespeare literature and other poetic literature. It means everything published scientifically in that field. So books, journals, articles, blogs, anything actually that can relate to the scientific thing is called literature. So after you have a research question and you observe something, you read the literature and what people are actually talking about this question. Number 3, you formulate your hypothesis. So what is hypothesis? For example, I have a drug X, okay, and I believe that that drug X is better than Panadol It can reduce headache. It's gently on the stomach, better than Panadol. So my hypothesis as a researcher, as someone who has the research idea, is that the drug X is better than Panadol, because that's basically why I started this thing. So number one, you formulate your hypothesis saying that drug X is better than Panadol. This is called the research hypothesis, or the alternative hypothesis, which is the researcher's hypothesis, the base that you start on your research on. So after you observe something, you read what people have published in that specific field, and you have your hypothesis, your decision that you want to make sure of is that drug X is better than Panadol. You choose your design. So this is where it actually starts to get more technical here in the study designs. So, for example, am I going to get that drug X and give it to hypertensive patients and see its results on a long term, for example? Or I'm going to go to patients that already take that drug X without me interfering in anything, and I just, like a radar, I'm recording the results when they take that specific drug. Or am I going to go to records, old hospital records, for patients that took that drug X and see their effects in the past, not in the future? So there are many study designs that we can take. So you choose your study design based on your hypothesis, based on the outcome that you want, and after that, you have your study design ready to start your clinical research field. Number 4 is the protocol, or the ethical approval. And this is a very crucial and important part. And this is the cornerstone of this whole cycle, because take it from me, any research field, any research project, any research study that involves human being, whether asking them something, whether giving them drugs, whether taking their information, you have to have an ethical approval. It's called an ethical approval. You get it from your, it's called an ethical approval committee, or the IRB, the Institutional Review Board, whatever it's named. It's already there in your college and your university. It's called the ethical approval committee. You have to present your idea, your protocol for the whole thing that you want to do, and they assess: is it safe for the patients? Does it go according to the ethical guidelines that we work according to? Because again, any work that involves human beings, whether giving them drugs, whether giving them surveys, whether asking them by interviews, any research projects that involves human beings, this is very important again, because a lot of people do a very, very good work that can take years and years of practice. And after they finish their whole thing and write their paper and send it to journals to publish it, and they don't have an ethical approval, their work will be perished, not published, okay? So this is a very important part. Number 4 or number 5 is the implementation part. You actually start doing the thing. You actually give the drugs to the patients, or you take the records. You're like the radar in some study designs. And after that, you get your data, you get your results, the data collection. After that, you enter these collections, these data on a statistical analysis program in your computer to analyze them in a specific and complex way that we don't want to hear about today, to get your results, which is the data analysis. And after that, you write your results on paper, which is the writing, the manuscript, and you get it for publication. So this is basically, when we say research or research study or research project, that's basically the whole idea. You start with an idea, you read what these people are talking about this thing, you get your hypothesis and your decision or the outcome that you want to reach, then you choose your study design. We're all set, get the ethical approval, start the actual work, get the data, analyze the data, write your results in your paper, and get it for publication. All right, so anyone does have any questions on this part? If you have any questions, raise your hand.
Question
Okay.
From Elif Üsküdar. How detailed should the hypothesis be?
Okay, so the hypothesis, I didn't want to go in details in that one because it's a bit complex, but the hypothesis, you have 2 hypotheses. You have something called the alternative hypothesis, which is your hypothesis, as I've said before, the researcher's hypothesis. So if I want to make sure that, or want to investigate whether drug X is better than Panadol, so my hypothesis is that drug X is better than Panadol. There is another hypothesis called the null hypothesis, or the zero hypothesis, which is basically the opposite of your hypothesis. So I want to say that drug X is better than Panadol. This is the alternative or the researcher's hypothesis. The null hypothesis would be what is that drug X is not better than Panadol. Actually, Panadol can be better than my drug X, or they can be equal, not that drug X is better. So you state this in your protocol. It's called alternative hypothesis. You just write this literally, alternative hypothesis, drug X is better than Panadol in reducing headache, for example. Null hypothesis, drug X is not better than Panadol. Panadol is better, or they are equal, they have equal effect, or there is actually no comparison between them at all. Drug X cannot be working on headache at the first place. It can be working on blood pressure, for example, not headache. So these are the two hypotheses that you state in your protocol. Okay, we have another question.
There is also from also Elif Üsküdar. Do you always need both in the paper?
Both, not the paper that is published online, but in your protocol that you present to the ethical approval. In that protocol that you write your research question, you specify what you want exactly, you specify your study design, your outcomes that you want to investigate, and you write your hypothesis, the alternative and the null one, as we said before. When you get your ethical approval and you're ready to go, you start your work and never write about that again in the paper that is published online. All right.
Okay, thank you. There is also one more question from Gamze Turut. Where do we find the literature about a topic? Just write it on Google, or is there a website? Or is it the one you said with doi.org?
Doi.org. Okay, so this is basically one of the things that we're going to talk about in the practical part at the end of the webinar. So make sure you stick to that part so that we don't burn events. And I will go into that in details later. Okay, so and now divisions.
Okay.
All right, awesome. Thank you for your questions, guys. So now the divisions of medical research. So when we say research, we know the cycle that we go according to. But what is actually research, not clinical research? When we say research, we mean two types, either primary research or secondary research, basic science and clinical. What is all that? Let's stick to the one on the left, basic science research and clinical research. The basic science research is actually the one that goes into the lab with lab animals like mice, monkeys, cultures, on an agar plate, for example, or whatever that is called. So that is called the basic science research. The second one that deals with patients is called clinical research. That's why it's called clinical, because it deals with patient, the one that gets the ethical approval, giving patients drug, etc., for example. So in both of them, we have something called primary research and secondary research. The primary research is the research that you do on your own, and you are the source of the data. For example, for the drug X and Panadol example, I give the patients the drug X, and they already, for example, take Panadol, and I take the results from them and see the effect of drug X. So I am the source of data. No one else has done this before on a published paper online, for example, and I'm taking these numbers. No, I am the one who's doing this. So this is called primary. You are the primary source of data. The secondary one is the one that is already published online. So for example, if Mika has a research paper published anywhere speaking about this drug X, and she had her own results, and I took those results, so this is called secondary research, because this is her results, not mine. So in basic science research, you can do this on your own, which is called primary research, or get research papers already published online, which is called secondary research, and the same for clinical, primary and secondary for clinical research. Okay.
COVID-free.
COVID-free, awesome.
COVID-free.
Awesome. Okay, so now is the time for your participation. I would like a volunteer, 1 or 2 or 3 or whatever you want, to tell me how research is in this pandemic period. What's your observations on research? Have you seen research that has been done correctly a lot, faulty a lot, less research, a lot research, the vaccines thing? What do you think about research in this in the past period? Feel free to open your mic and just speak. Any volunteer?
Okay, can I say my opinion?
Yeah, sure.
As I know, there is also a lot of research works during pandemic. But also there is one question: what about the qualitative? That's why there is a lot of low qualitative papers and high qualitative papers. And also there is a lot of falsifications, as I know, and duplications. In order to stop it, we must know some aspects to prevent it, as I know.
Okay, great. You've actually said the exact answer that I want. Does anyone have any thing to add?
Feel free,
Oh.
guys.
Okay, thank you, Mika, for your answer. So actually, this is the thing that I want to talk about. There is a lot of research that has been published recently about COVID. And actually, this is called a preprints or unethical trashy research, if you can say. So basically, we have two kinds of journals. The journal that is a very good, renowned journals with some people behind their desks. When they receive a paper, they review it, which is called peer review. They review this research paper. Does it go according to the ethics committee? Is it done correctly? Is it a high quality one? Are there any vocabulary or scientific writing mistakes or methodological mistakes? They review it, which is called a peer review. And then when it's good to publish, they publish it. So this is called a peer reviewed journal or a peer reviewed article. Recently, there has been a lot of preprints, which is called the preprint websites. Preprint websites are actually you have some sort of a website like ResearchGate or Facebook, for example. When you want to post anything on Facebook, no one actually says you have to say this before posting your article or for your material. You just write whatever you want and you publish it online and people see it. So this is basically what preprints are. Preprints are websites for research. It's like Facebook without peer review. You just write your article and you publish it and everyone sees your results. So this is not very good because a lot of research papers have many mistakes. They have to go according to the peer review process that I've said before to make sure that it goes according to the quality steps that we're going to talk about later in this webinar, unless it's going to be a trashy, unethical research. So some of these preprints are called the archive. The XIV refers to archive. So we have this one, which is called the bio archive, for example, the RG archive, the chem archive. These are all websites. You can type any of these names on Google and you have the preprint journals. It's basically like the normal journal, but it's not peer reviewed. Anyone who wants to share their results, they share it online. So why do we have a lot of these preprints recently? Because it's basically freaking pandemic. We have thirst and hunger for evidence. We do not have a well-established treatment for COVID-19, for example. So everyone does their best and the research to make sure that they have a positive and good results in this pandemic. So whenever anyone have a research project and they believe that they have a good results, they share it immediately on the preprints so that everyone sees the results. So this is the nature of the pandemic. We need evidence to treat this this pandemic. So that's why we have a lot of preprints and trash and ethical research. So how should we approach those preprints and how should we judge them? Whether we take the results immediately and apply it on clinical practice or take the peer-reviewed one. We're going to talk about that later in the practical algorithm that's coming soon. Okay, so the hierarchy of evidence is something very important for evidence-based medicine. Some of you may have seen this before. It's a pyramid, basically, of many steps. The bottom is the least important one, and the top is the best one with the best example. We have something in the chat here. How does get the peer-reviewed review paper? Okay, Gamsi, thank you very much for your question. We're going to talk about that later in the last part. Okay, so back to the hierarchy of evidence. It's basically a pyramid. The base of the pyramid is the expert opinions or animal studies or editorials. For example, a doctor, your family medicine doctor has advised you to take this drug because it can treat headache, for example. This is called an expert opinion. The top of the notch one, which is the systematic review and meta-analyses, are actually the ones that involve many research projects that have been published on COVID-19. We gather all of these research products that have been published speaking about the treatment of COVID, and we get one result, and we get the common drug that they actually are advising us to use. So this is a very basic definition for systematic review and meta-analysis. So the top of the notch, the best one are systematic review meta-analyses, or the RCTs, which is the randomized clinical trials. Clinical trials is the trial that you try a drug on patients. That's why it's called clinical trial. You try drugs on patients and see its effect. So which type of these study designs or evidence ways that we should use in the pandemic, or that have been widely used in this COVID-19 period? Actually, it's based on potential for bias, because expert opinions cannot have that very much evidence quality, because it's not been tried on patients. A lot of patients, like in the RCTs, because the randomized clinical trials, you try the drugs on many patients and see the results and see which one is better for you. But the expert opinion is just an opinion of a doctor. So why are both being used during the pandemic, the top and the bottom? Because again, it's a freaking pandemic. No one knows about this coronavirus thing. So doctors and professionals work according to their previous experience and previous knowledge. So COVID-19, for example, caused pneumonia. So we take the drugs that treat pneumonia to treat COVID-19. It's simple math. So expert opinions are very important in this thing. And the top, of course, the randomized clinical trials are very important, because you want to establish a new drug that has been shown to actually treat COVID-19. So the top and the bottom are the ones that are widely used during the pandemic. So do we have any questions still now? Where do we find literature about topic? Yeah, we've answered that before. We're going to talk about that later. Do you always need both in paper? Okay. A lot of disinformation and not verifiable articles about COVID-19. Yes, exactly, Ruqayya. Thank you. Gamzi, how does one get a peer review paper? Yeah, we're going to talk about that later also, Gamzi. Thank you for your question. Great. So now we're going to talk about the clinical trial, that one on the top, the one that you try a drug on patients. So when we say a drug is an FDA approved, it's safe to use, what are the steps that should go until we say that drug can treat COVID-19 in a clinical trial? Actually, it doesn't even start with patients. It's called the preclinical phase, that one. It's the phase before even going with patients. Considered as an introduction between you and the drug. So, hello, drug X, my name is Ahmed. And the drug says, hello, Ahmed, my name is drug X. And when I shake his hand, I see that it's safe. It's not hitting me, for example, or saying, or insulting me. It's safe. So, okay, you're safe. Number two, how do you interact with the body? For example, do you have some specific catalytic enzymes? Do you induce some hormone changes in the body, for example, based on your nature as a drug? So this is called the preclinical study, the preclinical phase, the lab and normal studies. It's the lab phase. You test the drug on an agar plate, for example, or an animal, or lab animals, to get introduced to the drug and see what its effect on normal hormones, enzymes, its safety, etc. When I make sure that I know this drug a bit well and I'm ready to use it with humans, I go to the phase 1 clinical trial. So the phase 1 clinical trial is applied on 20 to approximately 80 or 70 people, not very much large number of people or patients. And this phase is only to make sure that this drug is just safe to use. No testing the efficacy or the efficiency of the drug, no testing how it can treat the pandemic or the disease that we're investigating about, just to make sure that this drug is safe for patients. When we pass the phase 1 clinical trial and make sure that this drug is safe, we go into phase 2 clinical trial. After we've been introduced to the drug and make sure that it's safe to use on humans and know its pharmacokinetics and pharmacodynamics, pharmacology things, we go into the further study of that drug. We go into the side effects, to what extent is it effective? So we increase the number of patients from 100 to approximately 300 subjects or patients. And we test this drug and see its see its effectiveness and side effects. Number 3 is the phase 3 clinical trial. We do it on a larger scale. We take from 1,000 to 3,000 people and see more of its side effects and more of its effectiveness on the patients. And actually, at this phase, it can be used widely by the general population because at phase 3 clinical trial, we've established that this drug is safe. We know its side effects, we know its effectiveness, the dosage, the pharmacokinetics and dynamics things. We know everything basically about the drug. But the only thing that we have left to do is testing it on a wider scale, on a large number of population, commercially used in hospitals and by doctors. So if it's a pandemic, if it's an emergency situation, after phase 3 clinical trial, we can use it on population. And some drugs that have been actually approved by the WHO, which is called the emergency use, something like that. After the drug passes the phase 3 clinical trial, we can use it on the population. Furthermore is the phase 4 clinical trial, which is called the marketing phase. The marketing phase after the drug has been approved and it's been sold to the patients in hospitals and prescribed by doctors. We furthermore investigate on the long-term side effects, the long-term effectiveness of that drug. So this is what it's called a clinical trial. We try the drug on patients and see its effect. And that's why it was one of the top of the notch of the hierarchy of medicine. If you can see, it's on the top here, the research, the hierarchy of medicine, the randomized controlled trials or the controlled trials are the best one because we've investigated this drug thoroughly through the safety, effectiveness, side effects, and make sure that it's safe and can treat that disease specifically. So preclinical, phase 1, 2, 3, and 4 are what is called to be clinical trial. So now we've known what is research, what is medical research, how research has changed during this pandemic period, and we know a little bit about clinical trials and expert opinions and their importance in this phase. Now we have the most important one, which is the evidence-based medicine steps. How can we approach these papers? Remember the ACE inhibitors and the lung cancer one. Remember the cardiac health and the omega-3 one. Remember the hydroxychloroquine papers that have been recently published a lot on that specific drugs. How can we approach these drugs, these research papers? Should we take this into clinical practice or not? This is the evidence-based medicine steps. So, critical appraisal. The most important one in today's webinar. Critical appraisal goes into 3 main categories. Number 1, relevance, validity, and objective criteria. Let's take the first one, which is relevance. You can actually see this a bit funny, but when you search for a drug that treats COVID, you have to read a research paper that talks about COVID, not osteomyelitis, for example. And you'll find it shocking, but actually there has been a recent paper that has been published about treating COVID patients, testing a drug, and they haven't mentioned anywhere in that research papers that these patients have even had COVID. So for God's sake, you're testing a drug on COVID patients. Why don't you have a COVID patients in your paper? So this paper is not relevant for your hypothesis. Your hypothesis is seeing that this drug treats COVID. So if this paper is not talking about COVID patients, how can we relate between COVID patients and these drugs? So this is simple, but you have to make sure that the paper that you're reading is actually relevant to your question, to the thing that you want to investigate. Number 3 is the objective criteria. The objective criteria are classified into inclusion and exclusion criteria. What is that? I want to see if hydroxychloroquine can treat COVID-19 patients or not. So COVID-19 patients is a very wide and wider scope term. I want, for example, COVID-19 patients with specific comorbidities, the COVID-19 patients with hypertension and diabetes, for example. So when I read a research paper, I have my inclusion criteria. Number 1, COVID-19 patients. Number 2, hypertension. Number 3, diabetes, for example. I may go furthermore into more than 50-year-old males and females, or less than 50-year-old males and females. So exclusion would be non-COVID patients, non-hypertensive patients, non-diabetic patients, patients less than 50 years old. That would be an exclusion criteria for me. So when you read a research paper, you have to make sure what exactly do you want to learn about that paper. Is it relevant or not? Does these objective criteria, inclusion, exclusion, meet your research question or not? You have to make sure of these 2 things. Number 3 is the validity. Validity can be classified into internal validity or external validity. The validity, you can replace that word with quality for simpler use. So the internal quality or the internal validity is the way that this research paper has been done. Do they give the patients the drug correctly? Do they assess the patient's results correctly? Is it run in a high quality manner? Are there any methodological bias or something? This is called internal validity, how the research paper itself was done. The external validity is the generalizability. So as we said before, not because a research paper said that, for example, ACE inhibitors cause lung cancer, we take all the ACE inhibitor drugs away from all hypertensive patients around the planet. This is not sensible. We have to make sure that after reading the research paper that you're assessing or you're appraising, that these results can be generalized over the whole population. Because if you see, for example, this one here, the wider circle, these are all COVID-19 patients around the globe. According to the Johns Hopkins Corona map, we have around 54 million cases around the world. So it's not sensible to test your drug on all the 54 million cases around the world. This is not reliable. So you take only samples from these COVID-19 patients. For example, from the 54 million cases, you just take 1,000, 15,000, 100 million thousand, for example, whatever the number that you want. You take just samples from this target population and you work on them. You give them the drug, you do the survey, you take the history of them. So when you get results, this result is from your sample, not from the population, the whole target population. So to apply the results of your research paper, it has to be generalized on the total population. How can it be generalized by the total population? This is what we're going to talk about after this very slide in the algorithm that we're going to talk about in a minute. So again, the critical appraisal, you think about three main things. Is it relevant? Its inclusion exclusion criteria, is it relevant to you? The internal validity and external validity that we're going to talk about more. If you go through all these critical appraisal process, you're good to go. You can advise and prescribe this drug to your patient. So now, the very entertaining part. You have a new study published, the hydroxychloroquine part, one of the millions of papers that have been recently published about coronavirus. There has to be two kinds of publications. The preprints that we've talked about before, like the bioRxiv or the ChemArchive, where any researcher has any work can publish it anytime and everyone can see their works without peer-reviewed or peer-reviewed journal. The peer-reviewed journal is the journal that have reviewers that make sure that your paper is done correctly. So we had a question before about how peer-reviewed is going. So basically peer-reviewed is a kind of a list. For example, I'm the editor of the journal, I'm the big boss of the journal, and I have submissions from people who want to publish their journals in my journal. So I see these manuscripts or these paper that they want to publish in my journal and see, does it go according to the scope of my journal? Because if I'm a hypertension journal and I get a diabetes paper or manuscript, it's not relevant to the scope of my journal. So my job as an editor, one of the many jobs actually, is to make sure that submissions go according to the scope of the journal. This is number one. When I have a manuscript published about hypertension, so okay, it goes according to my scope, I now have to make sure before publishing this paper that it's a high quality paper, no mistakes in them, it has an ethical approval and goes according to the quality 10 checklists, for example. So I give this paper to my reviewers. Reviewers are actually can be freelancers, independent researchers that have extensive experience in this topic. They have kind of a list. So for example, number one, do they have an ethical approval? So I am as a reviewer, I see, yeah, this paper has an ethical approval, check. Number two, is their statistical analysis done correctly or have they used a wrong method, for example? No, it's done correctly, check. So each journal has its own checklist for the reviewers according to the type of the research that has been submitted. And if it goes according to these checklists and it's good to go, it's good to publish, the reviewer approves this manuscript. It's peer reviewed already and it can be published. So of course, this process, this strategy is much better than the preprint one. The preprint, you as an independent researcher can publish immediately your results and everyone can see your paper. But the peer-reviewed journal or the peer-reviewed process has a reviewer that makes sure that everything goes according to a plan, goes according to the high-quality plan, and before publish it online. So a new study published, if it's published in a preprint journal, please do not share this one, even if you can see it a good one. Because let's talk about a thing. Not everything that you read online can be published with the general population. For example, the ACE inhibitor and lung cancer one, the widely used antihypertensive drug ACE inhibitors. If you share this paper, even it's a peer-reviewed journal, if you share this paper with the general non-medical field population, they will be afraid and there will be a generalized panic around the world from that drug that it causes cancer. And they would actually may die from hypertension, not from cancer, because the drug can be actually causing cancer, but in very high doses on a very long term. So it's not actually practical to use this strategy that may lead to lung cancer, and that the doctors are prescribing the drug in a sensible dosage that doesn't cause lung cancer. So not everything that you see online, whether preprint, specifically, of course, preprint or peer-reviewed journal, can be spreaded and distributed along the general population. So back to our algorithm in new study published. If it's a preprint journal, please do not share until it's peer-reviewed and appraised by yourself and by other researchers, and making sure that it's relevant and high quality, then you can share it with the general population. Number two, the peer-reviewed journal. Number one is controlled. So what does it mean to be controlled? For example, I have two highlighters here, this pink highlighter and this blue highlighter. Let's say that this is a COVID-19 patient, the right one, and this is the drug that I want to test. So I only have that COVID-19 patient. For example, I have 10 patients. I give them the drug and I see the result. They're getting better. Awesome. The drug is better. The drug is amazing. It helps decrease the COVID-19 symptoms. No, because if it actually gets better, the drug is good. If it doesn't get better, the drug is bad. That's what we don't want in COVID-19. We want to know to what extent is it good. To what extent does it decrease pneumonia? To what extent does it normalize the oxygen saturation in the blood? And we cannot know that until we have a comparison person here. We have another healthy person. This is the red one, the COVID-19 patient, and this is a blue healthy person, completely healthy person. He's a control, he's a comparison. He's another arm, another group comparing to the experimental or the disease or the one with the disease. And I give the COVID-19 patient the drug, and I give the same drug to the healthy patient, and I see the results. So if I have a baseline, for example, let's say oxygen saturation. So the COVID-19 patients have oxygen saturations below 92%, and healthy persons or healthy individuals have oxygen saturation 95% or more. So if I give this drug to the normal person and his oxygen saturation becomes, for example, 97 or 98, and I give this the same drug to the COVID-19 patients, and their oxygen saturation goes, let's say, from 75 to 90. It's very good, because according to the control, according to the comparison that we have, the normal person has become more normal in a very sensible way. From 95 to 97, it's acceptable. It does not have an extreme values of going up to 100 or more. And the COVID-19 patient has been improved from 70 to 90, for example. Okay, let's say we have a Parkinson's disease. Parkinson's disease is a very widely famous neurodegenerative disease that has something called placebo or psychological effect. We here have another drug, that blue drug. It's nothing. It's absolutely nothing. It's an inert material. It looks exactly like the drug. It tastes exactly like the drug. It smells exactly like the drug, but it has absolutely no difference. So if you have a placebo in that hand and your drug in that hand, you wouldn't be able to tell the difference unless you already know this is a placebo and this is a drug, okay? So if I have a Parkinson's patient over here and I give him the drug, all right, and I have another healthy person over here and I give him the placebo, the drug that has absolutely no effect, I can see the psychological effect of the drug based on this comparison, because if that normal person takes that imaginary inert material drug and feels that he's getting better, he has less tremors as a healthy person. He doesn't have Parkinsonism, but of course, all of us has some kind of a fine tremors. So he doesn't have any tremors anymore. Is this actually a drug? Does it actually reduce his tremor? No, it's a placebo. It's nothing. It's an inert material. So it has a psychological effect. It has a placebo effect. Okay, let's go back to this normal again. So both patients, the Parkinsonism patients and the healthy patient, both have taken the drugs in same conditions, assessed by same physicians, in the same environment or the same hospital, for example. This is one study, this is one research study, but with 2 arms. So I already know that in my conditions, in my environment, my drug, whether it's a real drug or a placebo, an inert material that doesn't do anything, there is a psychological effect of this thing. So I assess, for example, we have a 5-point psychological effect of this drug. So when I test this drug on the COVID, on the Parkinsonism patient, and I subtract this 5-point psychological effect, I'll get the pure effect of the drug. You know what I mean? Again, if I have a Parkinsonism patient, I give it the drug. The effect that we get is partly psychological and partly actual by the drug. So how can we know what is the psychological effect of these results to subtract them from the outcomes that we have and get the pure outcome of the drug? How does it actually reduces tremors in Parkinsonism? So we take an imaginary drug, a placebo that doesn't have any effect on any person, and in the same conditions that we give the Parkinsonism patient that drug, we give that placebo to the healthy patient, the completely normal individual. We give it the placebo in the normal condition or the situation that we give the Parkinsonism patient his drug. So we calculate to what extent that drug or that placebo was had an effect or a psychological effect. Then we subtract them from the drug that actually the Parkinsonism patient has taken to get the pure result of that drug. So let's say that we don't have that control group. We don't have that individual. We only have the Parkinsonism patient. When we give the Parkinsonism patient that drug like that, and the patient has been improved, all we can say is that he's been improved and the drug is good. To what extent? Is there a psychological effect? Are there any other variables that have been interfered with the results? We don't know. Why is that? Because it's not controlled. There is no comparison to judge. You know what I mean? So if we have a drug on a diseased population and another population to compare to, we know to what extent is the drug good. We know how much does it reduce hypertension, how much does it treat pneumonia, how much does it improve the oxygen saturation. So if this study is not controlled, just having one arm, one population, giving them the disease, please do not share these results. They can be biased. They can have low evidence, because if the patients are getting better, this is just the interpretation of the drug is effective. But to what extent, we don't know, because there's no comparison in the first place. And if the patients are not getting better, this drug is a BS, because actually, again, there is no comparison to judge to what extent is this drug harmful, for example. All right. I'm going to stop here to see if you have any questions regarding this very part, because I know it may be confusing, but it's very important.
Yes, we have questions.
Okay.
There is a question from Elif. Isn't FDA specific to USA?
Yeah, exactly. But I mentioned FDA as an example. So you can have your own association that approves drugs in your country. I just mentioned it as an example of a drug being like effective for good.
Okay. Thank you, Elif. There is also a question from Rugia. So, according to hierarchy of evidence, most verifiable sources are meta-analysis articles?
Yeah, exactly. Thank you very much, Rugia, for your question. Let's go back to the hierarchy of evidence or the levels of evidence. So the top of the notch are, of course, systematic review and meta-analyses, but with them goes clinical trials, because systematic reviews are the kind of the secondary research that we talked about in a few minutes ago. So for example, Mika has published a research paper. I have published a research paper. Elif has published a research paper. Gams has published a research paper. And they all want to test whether is Panadol better than drug X or not, okay? They all go to the same inclusion criteria, the same exclusion criteria. They want to know the exact same thing, whether is drug X good or not. So another, for example, let's say Rahma, we have Rahma here. So Rahma wants to know whether drug X is really good or not, because I have my paper and I say drug X is good. Mika has her paper and she says drug X is not good. Elif has his paper and they say that their drug are not good. So is it good or not, for God's sake? So Rahma takes all these already published research papers online and gather them together and list their results in a one table, a summary table of the results of each and every one of us that has their own research paper done on the same topic. And actually this is called a systematic review. That's why it's called systematic review. Systematic because there is a system. There are very specific inclusion and exclusion criteria and a topic that you want to assess and review, because it's a review. It summarizes and reviews the evidence published. We can go furthermore if the results has a very good numbers that can be analyzed. We do something called meta-analyses. Meta-analysis is one kind of analysis. For example, if I say that drug X reduces hypertension by 10 points, Mika says that it reduces hypertension by 5 points. Elif says that drug X increases hypertension by 10 points. It doesn't reduce hypertension. So we want to know very good and specific result for this drug, not very different from different research papers, as we've said before. So Rahma does an analysis, the meta-analysis on all the numbers of all the research papers that she has gathered and reach one number, for example, saying the drug can decrease hypertension by 3 points. So this is 3 points has very much power as all of the other research papers combined together, not individualized as Mika, and Elif has published them separately. No, Rahma has gathered them all together, reviewed them in a one table, saying the result of each one of us, and analyze our results and reach one very powerful result that can translate the study design or the outcome they want to assess. So this is a very systematic and very complicated process that reaches a very powerful and a very high evidence research, because it includes a lot of research papers, not just one. Along with it, the randomized control trials, because as we said before, we try drugs by ourselves primarily, what are the source of raw data on our patients, and assess the results and the outcomes by ourselves and make sure that this drug is safe in the phase 1 clinical trial, make sure its side effects in the phase 2 and 3 clinical trial, and further monitoring on longer term of the side effects and the effectiveness of the drug in the phase 4 or the marketing clinical trial that we've illustrated before in that diagram, if you remember. So RCTs also are very good. So both of them are top of the notch hierarchy or the pyramid of evidence.
Okay, thank you. There is also one more question from Elif. In clinical trials of medicine and vaccine testing, does the study need to be double-blind?
Thank you, Elif, so much for your good question. We're actually going to go into that later. So basically, double-blind, when I say, let's go back to these very good, to my heart highlighters here. We have this Parkinsonism patient. I give him the drug. We have this very normal, healthy individual. I give him the placebo. So we have the experimental group, the patient group, the diseased group. We have the comparative group or the controlled group for comparison between both of them. So what is blinding actually means? So Parkinsonism patient takes a drug and he actually doesn't know if he's taken a real drug or a placebo. This is called blinding. So blinding is that the patient doesn't know what he's actually taking, but he must know that he can be taking the real drug or a placebo, which is illustrated in the consent. You give him a consent to consent that he is willing to join your research paper, your research project, apologies, and he knows that he may be taking the real drug and he may be taking the placebo drugs. Okay, so he knows already he can be taking either of them. So blinding, the patient doesn't know what drug he's taking, to eliminate all the bias that can happen. Because if the patient taking placebo, if this is a Parkinsonism patient and he knows that he's taking placebo and that the drug has actually absolutely no effect he will be complaining that he's not getting better, and psychological effect can interfere and goes more that I'm getting worse because I'm not taking the real drug, okay? And same goes for the placebo thing. The placebo can be taken the real drug, not a placebo that has absolutely no effect, and say that, no, this drug has many side effects. I'm a healthy person and I got more heart rate, for example, okay? So that is why blinding is very important. Blinding can be actually furthermore to the person or to the physician that assesses the patients. So for example, as we said before, the blinding is that the Parkinsonism patient doesn't know what drug he's taken, doesn't know if this is a real drug or a placebo. And I, as a physician who assesses this patient and see according to the checklist of the Parkinsonism thing, tremors or whatever, and see if this patient is getting better, if I know this is a Parkinsonism patient and he's taking the real anti-Parkinsonism drug, I will be careful when I assess him. I'll be careful in everything and make sure that I do my work perfectly. But if I know that this is a very normal, healthy individual who's taking a drug that has absolutely no effect, I may go easy with him, you know what I mean? Because he's not a patient, he's not taking a real drug, so I may go easy with him and be careless to a little extent. And that this is different environment from the environment that the other patient has taken the drug. As we said before, they have to be the same environment, assessed perfectly by both physicians or by the same physicians for both individuals, to eliminate all the possibilities of different and see the pure effect of the drug on the disease. So that is called blinding. Blinding can go either furthermore to a lot of other individuals, but we don't want to go in that in more details. That is the simple explanation of blinding, to eliminate all the possibilities that can go and interfere with our results. I hope I've answered your question correctly.
Thank you very much. Rugia says that double blind prevents Pygmalion effect.
Sorry, I can't see the question.
Can you hear me?
Yeah, in clinical trials of medicine and vaccines testing, does the study need to be double blind? No, it doesn't need to be double blind. But as we will go further more, for example, like the control thing, the study can be controlled and the study can be not controlled, can be just one arm. All right, it's not a rule for the study to be controlled. You may not have the resources to get a control group or the fund to get a control group. It can be only one disease experimental group. But of course, the controlled one have more evidence and higher quality of evidence, and you can interpret the results and generalize these results on the target population if it's controlled, okay? Because it's better, but it doesn't have to be double blinded. It's optional.
Okay, so there is a question from Rugia, and I didn't understand external validity in critical appraisal part. So we don't include whole population, and if so, how we select them, randomly or for exact criteria? And she says that double blind prevents Pygmalion effect.
All right, thank you very much, Rugia, for your question. So according to the, as for the generalizability part and the randomization, you've mentioned randomizing or choosing which sample that I'm gonna choose. This is actually the next part we're gonna talk about in our algorithm, so I'll save that for later. But the main or the concept of external validity is that me as Ahmed have done my research on Parkinsonism and get a controlled group, blinding, whatever, and I get a result. So my research paper is done on, for example, 10 patients, and you have done your research papers on 100,000 patients, okay? So which results are more reliable and can be used to treat whole Parkinsonism patients? Of course, your results, because you have more patients, more sample size. This is what it's called generalizability. We cannot treat the whole 54 million cases COVID-19 around the globe. This is not sensible. We cannot do that at all. So we just take sample. We take a specific number of patients in our province or in our hospital and go with the study with them and get the results from this sample. If this result can be inferenced, can be generalized, can be applied on the whole 54 million population diseased with COVID-19, this is what it's called external validity. This is what it's called generalizability. How can I know if this can be generalized or not? This is what the algorithm is for. We have some specific steps that we go according to. at the end of the step, the quality or the committee that is, for example, like the FDA in the USA, when they go according to the critical appraiser part of a specific drug or a research paper, if they see that this drug is very good and effective, it's put in a guideline, it's generalized on the whole population in the US, for example. So we're going to continue this algorithm in a few minutes. I hope I've answered your question.
Okay, thank you. There is a question from Leila Nagiva. How many research or people is enough for knowing this research or medicine is effective?
Thank you so much, Leila, for your question. It's a very good question that will actually be, again, discussed furthermore in the algorithm. We're going to talk about more about the sample size, which is the number of persons that you need to know if the drug is effective or not.
Okay, and one more question from Rugi Ibrahim there. And I have also one question. Where can we find preprint articles? Do normal people have open access to preprints, or it's closed to viewers?
Okay, so preprints are basically open access for all because, as I said, it's a preprint. It's something like Facebook. You just write and post anything you want, and everyone can see it and comment on it and share it, and has its DOI number, the identity card number that we've said before. So I can actually go and show you some of that. Can you see my screen? You're seeing Safari,
yes,
right?
Yes, no problem.
Okay, this is a very practical example here. So I can, for example, Chem Archive. So this is Chem Archive. This is a preprint website.
Wait, I can see your slides only.
You're seeing my slide? Okay, wait a second. I'm gonna share my screen now. Give me a minute.
Okay.
No share for my Safari. Awesome. So now you can see Safari, right?
Yes.
Awesome. Okay, so this is Chem Archive. I've just typed Google Chem Archive and I got into the website. So I can search bar here, for example, COVID. I'm just gonna type COVID. I'm gonna see a lot of research papers here. These are all papers that have been published on this website without peer review. Just the researchers have completed their paper, have written their manuscript, and just send it to the website. We can enter any of them. So here's the paper. The title over here, the downloaded, the preprint, the abstract, the whole thing, the funding. It's like a very normal journal, okay? So, but it's not peer reviewed. As I said before, it's like Facebook. The researchers have just completed the research paper, and they see that their results are very important, and that they need everyone to see their results because it's very insightful. So they just share it on a preprint journal until it's getting peer reviewed and published on a peer reviewed journal. So when you finish your results, because I see my results are very insightful and important for everyone to know, I share it on a preprint, and along with that process, I share it with a peer reviewed journal until it's published in a peer reviewed journal. It's available for everyone to see it there.
Okay, Rugia raises her hand.
I mean that. Yeah, I mean that, for example, you said that if it is not controlled by peer and it's not reviewed by peers, it can't be shared. And where can we know that it's peer reviewed, like where it's written? It is peer reviewed or preprint?
Okay, thank you so much. To knowing that it's peer reviewed or not, it's known by the journal name itself. So when you see a research paper published in a specific journal, you see the name of the journal. When you go into the journal's website, you will know there if it's a peer reviewed or not. So this is how to know the journal is peer reviewed or not. I'm sorry, I don't quite remember the other question. Do you have another question?
No, thank you.
Awesome, thank you. Okay, so
there is no question. Also Leila Mehmet raises her hand.
Yeah, okay.
Leila.
Okay, thank you. So when the scientist shares his research and this as a preprint, is this makes him like less credible, or?
Of course, yeah, it's less credible for us to use it as an evidence clinically applied on patients. As I've said before, we have some specific steps that we go through because peer-reviewed journals are better than preprint journal. Do you have some credibility to people who post on Facebook or not? it's the same question. If it's published on a very renowned article, for example, in the Washington Post, very known journal, we know that the Washington Post has some criteria. Not anyone can publish in Washington Post, but anyone can publish on Facebook. So you get the idea. You read the article and you benefit from the article, but you always have that small area in your mind that this cannot be like 100% high quality and can be applied on every patient, as they say in the paper, because I'm not 100% sure if it's high quality. It doesn't go according to the peer review process. When it goes to the peer review process and published and criticized, appraised critically by researchers, it's the time where we can share these results with patients, and even goes into the guidelines and widely used by the population. I hope this answers your question.
Leila?
Okay, great. So
Okay,
back to the algorithm. We say that new study published, if it's a preprint, keep it to yourself. Do not share it with the whole population. If it's a peer-reviewed journal, we go according to 5 steps. Number 1, is it controlled or not? And why is that important? Because if we have a comparison where my highlighters are, here are them. If it's a controlled process, you know to what extent is that drug beneficial, and you eliminate all the psychological effect that may be presented there, and make sure to what extent is that drug helpful or beneficial. Because if there is no control group, just your group, if the study, if the patient improves, this means that the drug is beneficial. If it doesn't improve, this means that the drug is not beneficial. And this is like very straightforward. Number 2 is randomization. So I said before, the randomized controlled trials, if you remember, I didn't say just controlled trials. I said randomized controlled trials. So what does actually randomization mean? Back again to the example of my very favorite 2 highlighters here. The pink one, for example, is the COVID-19 or the Parkinsonism or the experimental, the diseased group, whatever you can name it. The other one is the healthy individuals controlled comparison group. There has to be, of course, I don't have just one patient and just one control. I have, for example, like 100,000 here and 100,000 here, or 50 here, 100 here, whatever the percentage is between them. I have several numbers, of course. So if I have the patients here and the controlled here, all the patients are below 30 years old, of COVID-19 patients, and all the control groups are 50 more years old here in that group. Of course, because of the difference in their ages, there will be an improvement better in this group, because this group is younger, and we all know that younger individuals have better immunity, have better response to drugs, etc. Of course, age is a very important variable that can play a very important role in our research project. So if their ages are not approximately similar to each other, and there's an extent in the difference between them, if this group is very old, it's not going to improve better and cannot be compared to this group because they're not the same age. And the opposite is also correct. If the diseased group is very young, actually this can be done by some pharmaceutical companies to make sure that their drugs have better results. So I am, as a not very good pharmaceutical company CEO, for example, and I want my drug to be commercially used and widely used by a lot of patients, I get a younger diseased person, because I know that younger person have better results to the drugs and better immunity. And I get a very high or older person in the control groups. So by that, even if the drug is not very effective, it will show a difference in this group because they're young, they have better immunity than the correct group. So comparing, that's why it's called controlled, comparing to the controlled group, it's very good. You know what I mean? So randomization eliminates all these possibilities. We get 2 groups similar in age, sex, comorbidities, for example, in every possible way. We randomize them, for example, by a computer generator. You can go and type on Google random numbers, okay? So you have 10 patients here and 10 patients here. Who's gonna take the drug and who's not gonna take the drug? I'm not gonna do it on intention and get the younger people to take the drug and the older people to get it. No, I'm gonna go into a randomized computer generated number and say, just type the first one. I'm gonna type randomized number on Google and it get me 10, for example. So the patient number 10 is gonna take that drug. Up next, I'm gonna type a computer generated number. Patient number 50, it gets 50 on Google. So patient number 50 is gonna take the placebo, and etc. and so on. So I'm not doing it on intention, no. computers generated random numbers to me, and I'm randomly assigning the both groups, not by intention of having some specific group of specific criteria that I want pre-specified before giving them the drug. No, they're randomly assigned. They're similar in each variable, in age, sex, gender, etc., to make sure that we eliminate all the possibilities that can make a group of them is better than the other. If it's not randomized, please do not share it. It's a very good journal. It's a very good paper. Okay, it's well built. It's a high quality, but it lacks the randomization part, which is crucial for us. And we're gonna see that more in the practical part up next when we assess the hydroxychloroquine part. And we said that it's randomization, if it's randomized or not, and how it affected the results or their outcomes. Okay, so number one, controlled or not. Number two, randomized or not. Number three, the sample size that I guess Rukia has talked about before. Sample size, how many patients do we need in this experimental or the disease group? How many patients do we need in the control group? This is actually done by something called sample size calculation. It's calculated statistically by some specific rules and some specific programs. For example, if I want to assess if drug X can reduce hypertension by 10 points, so there is some specific very number for this to choose and to test on it. If I want to see if it improves the pneumonia case for COVID-19 patients by 2%, I have some specific number of patients that I need to test on, not picking, for example, 1,000 or 100. No, there's a specific number that is needed to test that thing. So sample size calculation is tested during that thing. If it's a sample size very small, if it's a very small sample size, this is not very good. We do not advise to do that because it makes sense. If you test your patients on a larger number or larger scale of person, it's very good, better than someone who tests on a very smaller number of persons. You get what I mean? Okay, so after sample size, I'm sorry, that's my cat mewing. Clinical outcomes. The outcomes that you want, no, thank you. The cat doesn't want to go into the webinar. The clinical outcomes. Clinical outcomes is it can go according to the hypothesis that you've stated before. See, cat. The clinical outcomes. You can have biomedical outcomes. For example, if it's in the preclinical phase, if you remember in the clinical trials, I want to see how this drug interacts with a specific enzyme. So this is the outcome that I want. Or I can go with clinical significance or statistical significance. So what does statistical and clinical significance means? Let me state this in very simple terms. As we've said before, when we test a drug on a population, you go and take a sample of the population, not of course the whole COVID-19 54 million cases around the world, as we've said before. So how can your results be generalized or not? This is what statistics tells you. Statistic tells you if it's generalized or not. This is called statistical significance. If the number, no matter how can we assess that, we don't want to go through very complex equations over there, but there is something, just know that there's something called statistical significance. If the statistics tells you that it is significant, so your results can be generalized over the whole population. If your result is not statistically significant, it cannot be generalized to the whole population. The results should be only concise to your sample, not the whole patients, okay? So statistical significance is not everything, because a lot of young researchers recently only aim for the statistical significance. If it's statistical significant, it can be generally used by the whole population or by the whole patient. But you have to have a far-sighted vision over here. You have to overlook this by the clinical significance. So let's say for COVID-19 patients, when I had this patient, and I've tried this drug on it, and for example, my outcome is the hospital stay after he is admitted to the hospital. How many days have he lived inside the hospital? Does he die in 5 days? Does he die in 1 day? Does he get improved actually and get outside of the hospital? This is my outcome, okay? So the hospital stay and his situation in the hospital. So if I try a drug and I see that my results is that the drug improves this person's state of COVID-19 state, and the results, the statistics tells me that it is significant. So what does it mean? That means that I can try this drug, I can work this drug on generalized population. I can take this drug and test it on people in Wuhan in China, in Germany, in Spain, for example. It can be generalized, not only by my patients. Okay, why is that? Because the statistics is significant. It can be generalized. But do we look to the clinical significance? What if I told you that this patient goes into the hospital? Normally, patients die after 5 days. Okay, this is the baseline. After 5 days inside the hospitals, COVID-19 patients die. And my drug has been tested and showed improvement, statistically significant improvement that can be generalized. But for how many days? For 6 days. Is that, for God's sake, is that a clinical significant thing? Patients die after 5 days of admitting to hospital. My drug makes it just 6. Does that make it a very good drug to be generalized over the whole population? Of course not. Yeah, the statistics is significant. It can be generalized to the whole population. If anyone used it, for example, he will die after 6 days, not 5 days. But is that my outcome? Is that the one that I want? Of course not. I want him to improve, to become better, not to die after 6 days, not 5 days. So not because the statistical significant, not because the results are statistically significant. No, you have to overlook it by clinical significance. Is it clinically useful to you or not? That is what you should look at too. So this is basically the algorithm. Now it's done. We've finished with more of the gossip part by me talking a lot. We're gonna go into more practical parts. Remember these parts again. A newly published journal. Is it preprint or not? If it's a preprint, please keep it to yourself. It's peer reviewed. Look at 5 things. Is it controlled? Is it randomized? How about the sample size and the outcomes that you want? Before going into the practical part where you will take part in, not me, you're gonna appraise and criticize these papers. We want to take some questions, I guess. We have 3 questions over here.
Rugia says, so statistically significant doesn't mean clinical significant, yeah?
Yeah, exactly. That's a very good advice, Rugia. Statistically significant doesn't mean clinical significant. Clinical significant is relevant, can be different from perspective to another according to the case and to the disease that you're dealing with.
Okay, there is no question. I think we can continue.
Awesome. So now, treatments and trials. Now I want you please to be more engaging, because we're now going to take some practical examples, and I want you to apply these knowledge that we've talked about in appraising these patients. So number 1, we have the very famous hydroxychloroquine drug. So this is the drug, Plaquenil or hydroxychloroquine. It's been published. You can see the cursor of my computer, right? That black thingy. You can see my cursor?
Yeah.
Or can you see just the slides? Yes. Okay, awesome. So the journal is called International Journal of Antimicrobial Agents. The title is Hydroxychloroquine and Azithromycin as a treatment for COVID-19, results of an open label, non-randomized clinical trials. These are the authors. The first author, he's called Philippe Gattray, and one of the last author, he's called Jean-Marc Rolijn. Okay, so now we know this paper, we know the title, we know the author, we know the journal. Let's go furthermore.
COVID-free.
COVID-free.
Thank God you remember. Awesome. Okay, so now look at this paper. Look at this picture. Apologies. This is a screenshot from the journal's website. Tell me what you can see, and if you have any note or something that you've noticed on this one, feel free to open the mic and tell anything that you see. I'm gonna give you like half a minute or 1 minute. So read thoroughly. Rugia, yeah?
Can you repeat the question again?
Yeah, okay, so repeating the question again, this is the journal. This is the paper published on the International Journal of Antimicrobial Agents. This is the title. These are the authors. Philippe Gattray as the first author, Jean-Marc Rolijn as one of the last authors. And we want to assess this paper and see if it's high quality or not. So you went to the journal's website to check it out, and you see this this scene here, this picture. Do you notice or see anything? Something suspicious or not?
Leila Mehmet Belli raises her hand.
Yeah,
okay.
no, I do not see any others indicated.
Okay, Leila. She doesn't see something suspicious or something here. Does anyone has any other opinion?
Impact factor actually here is 4. I guess.
Okay. Great. Okay, so the impact factor is 4. So this is a good indicator that it's a very good impact factor. Okay, Elif has raised their hand. Yeah, please speak up.
The time to first decision was 3 weeks, which is pretty low.
Mm-hmm. Okay, very good notice
Berkay
here.
raises his hand. Berkay.
I think the editor is also a writer for the.
Yeah. Awesome. Clap. Give her a clap, guys. She's very good. Okay, so this is actually a conflict of interest. Why is that? Look at the editor-in-chief, J.M. Rowling. This is the editor-in-chief of the journal. Let's go back to the journal, to the paper itself. The editor-in-chief is the same one of the authors of the journal. So it's basically like I'm the boss of the company, and I give myself a raise. You know what I mean? So I'm the boss. I can give myself a raise, of course. This is because I'm the boss. So this is a conflict of interest, is that one of the authors is actually the editor-in-chief of the journal. This is not illegal. It's not that bad, but this is a thing that you should put your eyes on, is that this paper may or may not. It has a low quality evidence here, and just because the editor is one of the authors, they had everything smoothly done and published the papers. So this is the first practical thing. So let's pass this one and go to this one. When we go according to read the paper, we've speak about the ethical approval. Do you remember it? It is that any research paper or research design or research study that deals with human beings, you have to have an ethical approval applied by your ethical committee in your faculty of medicine or hospital. And from then you can start and do your research. So let's read this part here. It says the protocol appendices and any other relevant documentations were submitted to the French National Agency of Drug Safety, blah, 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 and the French Ethical Committee for reviewing and approved on 5th and 6th of March 2020. Okay, so this is a very good indicator. The authors have applied their protocol to the ethical committee, and they've got their ethical approval on the 5th and 6th of March. Okay, let's continue reading in this article. So this is the methodology of the paper. What are they going to do? Patients, it says here the procedure. Patients were seen at a baseline for enrollment, initial data collection and treatment at day 0, and again for daily follow-up during 14 days. Okay, so the follow-up duration or the follow-up period that they're doing their study based upon is 14 days. So let's roughly calculate them. If they've got the ethical approval on 5th or the 6th of March, and they have started the work immediately on the first day and the 5th of March after immediately getting the ethical approval, and you count 14 days after that for the follow-up period, what's the day that you will reach? It's 14 plus 4 plus 5, simple math, it's 19th of March. Okay, so this is when it goes to a very, very, very tight schedule. When you just take the ethical approval on the 5th of May, follow-up duration for 14 days, it's 19th of May. This is only the data collection part. After that gets the data entry on the statistical analysis program on your computer. Then you write your results and you send it to the journal for reviewing, and it takes some time from 2 months to actually. It can take a whole year to review your paper, and then it can be published. Okay, so you can remember the first slide that we went before in the clinical research process. So let's see when this paper was actually published. 17th of March, boom, OMG. So they've taken their ethical approval on the 7th of May, or on the 5th of May, apologies. And if it goes to a very tight schedule, we said that after 14 days of follow-up, it will be 19th of May. But this paper has been actually published on the 17th of March, apologies, not May. It's been published on 17th of March. So this is a very, very, very tight and very, very suspicious schedule here, because it's not sensible. If you take the ethical approval on the 5th and you go follow-up duration for 14 days, it will be 19th of March without even taking consideration the data analysis and the sending to the journal and waiting for the peer review to finish and publishing your research online. So 17th of March is very suspicious. So this is something that you should put into your consideration when reading the paper, that something is not right here in this timeline or thing.
But it is only 2 days before the expected time. Like, for example,
yeah.
Does it make sense? Like, it is only 2 days before the expected time. Normally 19th March or 21st March it should be published, but it was published on 17th March. So there is only 2 days difference. Is it really enough that 2 days we consider it suspicious? Because only 2 days.
Okay, thank you very much for your question. Let's go back to the steps of clinical research again. So the authors have gotten their ethical approval here, this orange circle here, on the 5th and the 6th of March. So what happens after the ethical approval? It goes to the implementation. They collect the data from their patients. They enter the data under statistical analysis program. They get it analyzed. They write the manuscript and they send it to the journal. It takes peer review period, for example, from 2 months to a whole year until it's published. So when you get on the 5th, when you immediately and finish all of that data collection here, this green here, it should be finished on the 19th of March on a tight schedule. You still have a lot of process to finish. You have the data analysis, you have the data entry, you have the manuscript writing, you have the publication process and the peer reviewed process. So you still have a lot to finish. So 17th of March is, yeah, okay, it's 2 days before what it is supposed to finish, but on the data collection part, not the whole publication process. You know what I mean? Is it clear?
Yes, exactly.
Okay, awesome. Let's go back again to the next example.
I have a question.
Yeah, please.
So I have understood that this paper is really suspicious, and one of the authors is also an editor. So do you know if there has been any act on this peer-reviewed journal that the other editors said maybe, hey bro, what are you doing here?
Yeah, we're actually going to talk about that more. Yeah, we're going to talk about the end or the finale of this paper.
Okay,
we're getting started. We're simulating when you read a paper. That's what you be thinking about. Okay.
Yeah. Thank you.
Awesome. Okay, so let's go into another part, which is the patients and methods. Let's go to the yellow part over here. It says untreated patients from another center and cases refusing the protocol were included as a negative controls. So let's go back to the control part. When we say that a study is controlled, or there's a comparison or two arms of an experimental and a control group, how do we choose the control group? We choose it randomly. We choose the patients, we choose the control group based on our inclusion or exclusion criteria, all right? Well, it doesn't go according to that. We have a very specific inclusion and exclusion criteria. So what have these researchers have done? They have given their subjects or their patients and controls the protocol. And the patients that have refused the protocol and didn't like the idea of the study to take the drug, they've put them randomly into the negative controls as a control. So again, how can we choose controls? We have our inclusion or exclusion criteria. We give the consent to our patients or subjects, and they are allocated randomly in the two groups, and we proceed a research paper. But is that a good way of choosing controls? Patients who refuse to take the protocol are automatically put in the control group. Is that a good way or not? Is this representative or not? Can these controls actually help us interpret the results, comparing the both results or not?
Leila Nalieva writes that if 2 days after is enough, and also why we look editor.
Okay, so this goes back to the other one. If 2 days after is also we look there. I guess this was before we've talked about it. So 2 days or after is enough. No, it's not enough because we go back to the research cycle thing. So the data entry, it's not the end of the publication. The data entry would end at 19th, not 17th. If we consider that it ends 2 days before and they've taken only 12 days of follow-up, not 14, you still have a lot of process to finish. You still have the data entry, your analysis, writing your manuscript, sending your manuscript to the journal, reviewing it, and publishing it. So this can happen overnight. It takes from months to years. Also, why we look the editor, we don't actually look the editor in every research paper that you see, but some researchers have noticed this very thing in that paper and spread it to the scientific committee or the scientific community. So this is a thing to take into consideration. As I said before, when I'm the boss of the company, I can give myself a raise, and this is not credible. The person who should give me the raise is my boss, not myself. So this is the same thing goes here. This, as we see, actually, this paper has a lot of mistakes and faults as the timeline that we're seeing here and the control part that we're going to talk about in a minute later here. There is a lot of kind of, I don't want to say mistakes. Everybody's work is appreciated, of course, but some probable bias may be happening here. So being the editor of the journal and an author of the paper must have played a very important role for them to publish their journal, their paper in the journal. You know what I mean? Okay, I guess there are no questions here again. Okay, so back again to the control part here. This is, of course, not a representative control group because, as we said before, the control group should be taken according to an inclusion and exclusion criteria, according to the age, to the gender, to the comorbidities, the baseline assessment of them. So it's a very strict process of inclusion and exclusion criteria to choose the case definition. It's called the case definition. What COVID-19 patients are we going to take? What are their ages, their comorbidities, their gender, etc. The same goes for the control definition or for the control inclusion exclusion criterion that we're going to take to be representative and add comparison between both of them. We interpret the result. But if their process has been doing, when patients refuse to take the protocol and refuse to take the drug, they're putting automatically in the control group. This is not representative. This is not putting according to the inclusion and exclusion criteria. This is done by intentions of the researchers, and this can play a role in or making the outcomes not credible and representative. Do we have any questions in this part here?
No, there is no questions as I see.
So it's attrition bias, right? For example,
okay, great.
When the control group refuses treatment, this is attrition bias and it's not representative, right?
Yeah, exactly. It's not representative. He was not put as a control group at the first place based on inclusion and exclusion criteria. They were put in the control group based on refusing just to take the drug, which is not the healthy and the normal high quality process of choosing the control groups. So this would not be representative, as we said before. There is no healthy comparison over here. If the drug have shown to get an improvement in the patients, it would be just effective. If it does not get better, it would be just not effective. And we cannot say to what extent. Okay, let's go to the next.
Has anyone question?
But for example,
COVID-free.
Thank God was someone noticed the COVID-free. Awesome.
Oh, I forgot.
Okay, Maria. Go ahead. You had a question?
I mean, in attrition bias, for example, there is intention to treat conception that if even the patient refuses to take treatment, you consider them as an original group, for example. Can we prevent this and consider it representative of control group in this case? For example, you said that negative controls are not representative of the control group and we can't compare them. So how we can prevent it?
How can we prevent it is by choosing from the first place the control group based on inclusion and exclusion criteria without having attrition bias or selection bias. This is the simple answer. But how can we avoid it when reading the paper? the fault has already been made. You know what I mean? And I didn't want to say the specific terms for this, just not to get everybody confused, but bias is a whole another session. There's something called selection bias, attrition bias. There are some biases in blinding also. It's like a whole circle, a whole terms of bias that can happen in some methodological processes here. So what has actually been made here is called an attrition bias. More that in more detail, not to get someone confused, but the important thing that you need to know when reading a paper, when reading the controlled part, you should be seeing a specific inclusion and exclusion criteria. Based on them, experimental and controlled arms were selected. I hope this is clear. Okay, we can go to the part next to it. So this is the title again of the paper we're critically appraising. It says hydroxychloroquine and azithromycin as a treatment of COVID-19, results of an open label non-randomized clinical trial. Can you tell me, open the mic, feel free to add anything that you see suspicious or anything that you need to further more investigate according to this title? What do you see?
It's non-randomized, so it's suspicious. Non-randomized.
Okay, great. So it's not randomized. Anyone has any other thing that they want to add? Okay, so yes, that was the correct answer. It's not randomized. If you remember our algorithm, we look for 5 main things. Number 1 is the control, randomized, sample size, and the outcomes part. So this one is non-randomized. So let's go back again to the randomization part when we said that we have to eliminate all the differences between both groups, the experimental diseased group and the controlled comparative group, just to be able to interpret the results based on their similarities. So if we have a very group of older patients, of course, they would show little effect of the drug based on their old age, and the opposite is true also. If they're young, they will have a better results based on their immunity, better immunity. So let's go furthermore in this paper and see with ourselves their ages here. So this is the table that shows their criteria. You can see the ages in years over here. This is the hydroxychloroquine group, the treated patients, which are 20 patients. And this is the controlled patients or the controlled group, which are 16, okay? So this is represented in mean. Just look at the first one, which is the mean. The 51.2 is the mean age or the average age of the patients in the hydroxychloroquine. And the controlled group is 35.3, which is the average or the mean age of the controlled patients. So since this study is non-randomized, they were not randomized in an randomized computer generated, for example, way to eliminate all the difference. We had an age difference between both groups. As you can see, hydroxychloroquine mean age is 51.2 and the control groups is 37.3. It's almost 20 years different between both of them. So that would mean that the drug may not have been assessed correctly and shown the best way that it can work according to, because the hydroxychloroquine group is old. It's not similar to the control patients. And if the control patients were similar in their ages to the hydroxychloroquine, we would have been able to assess and interpret the results and compare them correctly and say that hydroxychloroquine can treat, for example, COVID-19 patients to a specific extent that we can say. So this is very obvious here. You can see in the age group, because it's non-randomized, you can see that the age is different here. If it would have been randomized, you would have been seen similar age between here. For example, 51 here and 50, or 51.2 and 52 or 53 here. They would have been very similar. Okay. I'm sad, no one has noticed the COVID-19 part. Okay, no problem. I know it gets a bit tiring over now. So let's go into the demographics part. Let's read this one. It says demographics and clinical presentation. We enrolled 36 out of 42 patients meeting inclusion criteria. So the sample size of this journal of this paper is 36 out of 42 patients. So they have treated 36 patients. What's your comment on this one? When you read this paper, regardless of the previous things that you see before, the editor being an author and the control part and the timeline. If you read the paper and you see that it's been done on COVID-19, a very important pandemic, you see that their sample size or the number of patients that they've used is just 36. What's your comment on that? Feel free to add anything.
42 out of 42 should meet the inclusion criteria. There are 6 people that remains without inclusion criteria. So
okay,
it would raise suspicion.
Okay, and what do you think of the 36 itself? Is it enough? Do you think it's enough to show a result that can be generalized over the whole population or not?
No, I don't guess that it's enough.
Isn't it still in the phase 2?
This is no. This is a normal clinical trial, not a phase 2 clinical trial. So the sample size part is very, very, very important, crucial. What? Apologies, I can't hear you.
Elif says sample is too small. Elif says.
Yeah, exactly. The sample is very small. So if you remember that we've talked about being controlled or not, being randomized or not, then the sample size goes according to specific calculations based on the outcome that you want to give you the specific amount of patients that you need to investigate your hypothesis that you've started the research because of. So when we put calculations, if we want a mortality rate going from 2% to 0% in conditions, regardless of the way that of this calculation, you need 767 total sample size to show this outcome. Okay, so again, sample size calculations, my outcome, I need mortality rate to be decreased from 2% to have 0% mortality rate. So how many patients do I need? I need around 776 patients. Basically from 700 to 1,000 patients is acceptable. Over that is not good, less than 700 is not good. How many patients does this paper have? It's just 36. So their results will be only tied to the sample that they've used. They're very thankful. We thank them for their good work, of course. We do not judge anyone, but we want to know if this results can be generalized over my COVID-19 patients, which is the important one that we do research because of. It's a pandemic. We want to find a treatment for COVID-19. So they've done their research on just 36 patients. This is not acceptable to be generalized over the whole population. So this is one of the main important pillars that we need to focus on, which is the sample size. I'll skip the COVID. Okay, thank God someone noticed. Awesome. So now we go into the outcomes, which is the last one. Remember, again, I'm repeating myself over and over because it's very important. Again, controlled or not, randomized or not, the sample size and the you want. So please feel free to this passage. This is the outcomes that the researchers have put to investigate, and tell me your opinions. Are these the outcomes that you want to see in a patient, in a research paper to decrease, for example, the mortality of COVID-19 or not? What do you think of these outcomes? Feel free to read this and open your mics.
Yunef writes, I have another meeting in 50, so I must leave. But
yeah,
I must
sure.
leave. But thank you so much for the effort you put for us.
Thank you.
Problem.
Thank you for your participation.
Sorry, Ahmed, your voice is breaking. So can you repeat the question once more?
My voice is breaking. Okay.
Yes, a bit.
Is it good connection now? Now it's clear. Yeah. Okay. Sorry, I have a shitty internet. Okay, so the outcomes over here, I'm going to read it for you. The primary outcome or the primary endpoint that they were assessing is the virological. The primary outcomes were also virological clearance and some clinical follow-up periods such as body temperature, respiratory rate, long stay at hospital, mortality, and the occurrence of side effects. research paper about COVID-19 that you want to treat a disease that has been killing a lot of thousands and millions of people, and you see these outcomes. According to what situation that you would find this passage useful or not? What do you think of this outcomes?
Actually, there is less time, like the washout period should be between the maybe. And here, for example, secondary outcomes are during the study period. Maybe it can be like biased, not correct, because after a period, the secondary outcome should be, it's my opinion, if I understand correctly and explain correctly.
Okay, thank you very much, Rugia. This is a very insightful notice. Okay, yeah, so she's actually correct, because when you look at the biomedical, as we said, outcomes can be biomedical. You can look for the statistical significance. You can look for clinical significance. So if you took it from the biomedical perspective, you can see that the virological clearance may not be the best way that you can be assessing the situation of the disease over here. You want more period, for example, or less period to investigate the virological clearance. This is from the biomedical outcome, and it can be different from me, from Rugia to Mika to Berke to anyone who reads the paper. They have their own hypothesis. They have their own view, the start that they want to read the research paper based upon. And we have the clinical significance that we've talked about before. So this is a pandemic. This has been killing a lot of people recently. So if we look for a clinical significance, we need a clinical outcomes, clinical measurements. For example, the body temperature, the respiratory rate, the length of stay. So the primary endpoint is virological clearance. And the secondary outcomes, which are the less important than the primary endpoint, are actually the clinical ones. More importantly, mortality, which is the most important one that we should be investigating. This is not an indication of that these outcomes are false or something. No, I'm not saying that. But from my perspective, as someone who wants to know the clinical significance of that hydroxychloroquine drug, to apply it to my patients, to have less mortality, to have a better improvement in the clinical symptoms, this is not the good paper relevant for me, you know what I say? So the primary endpoint is biomedical, and the ones that I want are clinical. So this is not suitable for my overview or for my research question that I think of while reading this paper.
What about the occurrence of side effects? Like it considers actually.
The side effects, I think they haven't been working on the side effects more on the hydroxychloroquine. Because they have not stated this in their outcomes. The outcomes was primary endpoint is the virological clearance, and the secondary are virological clearance and some clinical follow-up and side effects. So this can be actually be put under the clinical significance part too. So me as a researcher or as a physician who wants to decrease mortality and use this drug to decrease mortality in my COVID-19 patients, this is not the best paper for me because it's primary endpoint or the primary outcome is not a mortality. As for yourself, you can be looking for side effects. So this is also not the very best paper for you to interpret or take the results of. You should be looking for a paper that's outcome are primarily about side effects or mortality, not biomedical. You know what I say?
Yeah, I mean that, for example, you said that if there is not mortality that's noted in these papers, we can't verify that it's really, how can I say, verifiable journals, verifiable article, because mortality rate doesn't include. Did I understand correctly? Like
no, it's not a yeah, I get your point. Yeah, but I'm repeating myself. I'm not saying that it's an indication of a bad work or a less verifiable or credible paper. I'm just saying that four main things that you should be looking for when critically appraising a paper, like we said, controlled, randomized, and sample size. These three things are very important for the quality and the methodological quality of the paper that has to be there to be credible, and you go from there to the outcomes to see if they can be generalized or not. And as for the outcomes, you have many outcomes. You have the biomedical outcomes, for example, and the clinical outcomes. So according to your perspective, they have been working on the biomedical outcomes. Someone for example, a virology professor or scientist, his most important one is the virological clearance. He's not very interested in the clinical outcomes. But we as physicians, for example, not we people in webinar, but for example, myself as a physician reading this paper, I'm a physician and I want to use hydroxychloroquine drug to treat patients and reduce mortalities and clinical symptoms. So this is not the perfect paper for me to read, not because it's bad, no, but because its scope or outcomes or perspectives that they've been testing does not meet my hypothesis. You know what I'm saying?
Okay, I understand. I got it. Thank you very much.
Awesome. You're welcome. So another one here, retraction. We've talked before about the fate of some papers that have been showing some bias or mistakes. So it's like it's like a community. Actually, there is a website called PubPeers. P-U-P. I'm actually going to type it in the chat here. It's a very important website that you can check. Sorry, it's skipping. Where's the chat? Yes. I'm gonna type PubPeer. PubPeer is basically like a Facebook for research papers and scientific communities. PubPeer is when someone publishes a research paper, people and physicians and scientists talk about it. They assess it. They critically appraise it. Do you remember the timeline that we've talked about before? The one that the ethical approval have been shown as being given at the 5th or the 6th of May, then follow-up period of 14 days. Then the paper was already published 17th of March. This is a very tight timeline. Someone has actually been noticing that, and he's typed that on PubPeer, commenting on this paper. So PubPeer is a very important website for you to check the validity of the papers, to see what others have seen that you have not been seeing when reading this paper. So if there's a lot of methodological bias and methodological faults in the paper, it can be retracted, which is shown also here in this New England Journal of Medicine, which is one of the best medical journals in the medical field. It's been going according to a peer review. It's been critically appraised a very good way. It's a very renowned medical journal, but also it's been retracted. So this is an indication and a very good lesson for each and every one of us that not because the paper is published in a very good journal, we take it as it is and apply it to our patients. No, you have your role. You have your knowledge, your critical appraisal skills, the pillars or the categories that we've been talking about before, the control, randomization, sample size, and outcomes and methodological qualities based on your suspicious ways. For example, like the authors and the tight timeline, you look at carefully at all of these perspectives before applying the results of that paper to your patients, or put it in a guidelines, for example. And this is a proof that not everything you see is 100% correct and 100% good, even it's a very good journal. So always have that small part of you, suspicious part, the detective part of you, critically appraising every paper that you read. The fate of hydroxychloroquine has been announced by WHO that the WHO have terms for COVID-19. Why is that? Because the current research is not enough to show that it's been safe and good to continue treating COVID-19. Also, it has a very bad side effects on cardiac health. It increases heart rate, and I guess it has some arrhythmia side effects on patients. So WHO has discontinued hydroxychloroquine treatments for COVID-19, and it's already been announced on the July 4th of 2020 this year. So this is the fate of hydroxychloroquine. We have a little amount of area left. I'm just gonna give you some examples on a website called clinicaltrials.gov. So clinical trials are like what we've said before. It has several phases. It gives drugs to patients and see its effect. So before giving the patients the drugs, we've said before that any research study that deals with human, you have to have an ethical approval, right? So having an ethical approval, you have to present your protocol to the ethical committee. You have your protocol, you're basically the plan, the plan of action that you plan to do in your research study and apply it to the ethical committee and get the results for the approval or not. In clinical trials, there is a specific website for protocols, only protocols, not the result of the whole trial. It's called clinicaltrials.gov. So the title of this protocol is called Study to Evaluate the Safety and Antiviral Activity of a Remdesivir, which is the antiviral drug very widely used now, with patients, participants with severe coronavirus disease. The sponsor is Gilead Sciences. It's a very, very famous company now that has been producing remdesivir. And we can see here at the bottom, the condition is COVID-19. The intervention or the drug that they will be using is remdesivir here, and the phase 3 clinical trial they're investigating now. Okay, so this is our baseline now. That's remdesivir by Gilead Company or Gilead Sciences, testing remdesivir in phase 3 clinical trials. Let's go now. This is the study designs. It's an interventional study design, phase 3 clinical trial. It's randomized, which is a good way, but it's not. It's open label, which means it's not blinded. And the enrollment or the sample size that they're going to use in the study is 400, anticipated 400 individuals. Okay, so this is our baseline assessment here. This is the protocol of the clinical trial. They're basically the plan of action. They've not yet started the clinical trial itself, but the enrollment includes 400 patients. Some weeks after that, they've seen some people on PubBeer, also the website that I've told you about, that they have changed the 400 anticipated individuals into 2,400 patients or 2,400 patients or subjects. Okay, this is not normal. This is not very good to change the number of your sample size. As we said before, you have specific outcomes that you want to achieve, and there's something called sample size calculation, specific amount of people that you need to add into your research study to test and reach your outcomes. So the number is pre-specified, like the screenshot that I've showed you before. So changing the outcomes and from 400 to 2,400 is not a very good thing. Second thing over here, the last thing is, you can see here is 6,000 participants. Can you see this for the estimated and more? And this is actually, it can be a good thing or it can be a bad thing, because it can be a bad thing because this company may have been doing this to, as I said before, increasing the commercial investments or the commercial profit from this drug. Because when increasing the number of participants, you'll get a more credible research project. You'll get more differences between the groups, the experimental and the control groups, and the results can be generalized over the whole population. So you get more profit and more sellers to use this drug. And it can be a good thing because they may have changed the outcomes based on the plan or the protocol that they've used, and they've improved the outcomes that they want to investigate and calculated the sample size correctly and see that they need 6,000, not 400 as the first one. So again, this is not an indication of if it's a good or bad, but it's a thing that you have to put your eyes on and be the detective of your own self to see and estimate everything, every situation at its best way, and know every possibilities that may happen, because fraud occurs and improvement also occurs.
Rugia writes,
last thing.
Sorry, there is one question.
You have questions?
Parallel
Okay.
assignment, and but there is no blinding, right?
Yeah, if we go back to the the previous slide.
Corona.
If you mean, yeah.
I mean that what is the parallel assignment actually like?
So the parallel assignment, we have two groups, as we said before. We have this pink one, the diseased or the experimental group, and we have the controlled or the comparative group. Okay, so these are the drugs. So I have many ways to test drugs on these two both arms. I can give the diseased arm the drug and give the healthy one the placebo. Follow up for example, 10 days, 14 days, whatever the follow-up period is, and see the results. Okay, this is a situation. I have another situation. I can give each one the drug. After 10 days, I will have something called a washout period. I will take the drugs out of them, give them, for example, a resting period of 5 days, and then cross over the drugs, giving the diseased one the real drug and giving the healthy individuals the placebo drug, and also follow up for another 10 days. This is called washout period, the washout period, which is the period that we no arms were taking any drugs to eliminate the effect of the drug from their system, from their body, and then having a crossover design. So this is called a crossover design. So the parallel assignment or the parallel design is the one that they go parallel to each other at the same follow-up period. We don't have a washout period, for example, between them. We don't have someone discontinuing the drug and the other is taking the drug after them. It's a parallel assignment, parallel study design. Everything happens at the same time, basically. And there is no blinding, right? Yes, there is no blinding because it's called open label. And open label means there is no, that means there is no blinding. So we have blinded, single blinding, double blinding, triple blinding, whatever the blinding is, but there is something called blinding. Like we said, the patient does not know if the treatment they're taking is actually placebo or not. And there's something called open label, where everything is clear. Our cards are uncovered. The patient knows what drug they're taking. Me as a physician know whether the patient in front of me is a real patient or not, taking the real drug or not. This is open label study design, not blinded, not any way of blinding. And again, this is...
Sorry, what I'm trying to ask for, like, for example, the study designs that you gave examples are good examples of the clinical trials because of sample size is very big, right? But there is no blinding. So can it create a bias or can it decrease the effectiveness of the trial? Because, for example, double blinded more better than open label, as I know. So does it decrease the effectiveness of study design?
Yes, well, as I said before, it goes according to the statistical things that you do to calculate your sample size. So based on the outcomes that you want to achieve, you choose the sample size. As I said before in the study, in the previous slide, if we want to decrease mortality from 2% to 0% in COVID-19 patients, we would need 776 patients, or from 700 to 1,000 patients to test and really have this the accurate number of patients to show the difference that will give us to the outcome of decreasing mortality from 2% to 0%. If it's less than 700, it would show it would not be powerful enough to show the difference and not be credible enough. If it's way more than 10,000 than 1,000, it will be also something called overpowered design, and overpower is not ethical. Having a lot of patients or a lot of sample size in your study is not good because it may be going to the fraudulent side to show that your drug is very good for commercial purposes or something. So that's why sample size calculations are there to make sure that based on your outcomes, the sample size that you have is relevant and okay and accurate for it. Have I answered your question correctly?
Yep. Thank you very much.
Okay. Great. The last one, I promise. I know you're very tired. I'm tired too. So this is the last slide. We have COVID-free here. Okay, I know you're already tired. So this is a research paper. Awesome. Thank you, Layla. This is our title: the FDA-approved drug ivermectin. It's an anti-parasitic drug that inhibits the replication of SARS-CoV-2 in vitro. This is a very, very good research paper. It's very promising. It's been published in 18th of March. It shows that ivermectin actually inhibits the replication of the virus in vitro. So this can be very good because if human, for example, took it, it will reduce the replication in their body and reduce the symptoms and the virus effect. So you as a medical student or you as a researcher, someone who wants to know whether this drug can be generalized or not, what's your opinion, or what do you think about this paper just from the title of it? What can you suggest from it? So you have just the title: the drug ivermectin inhibits the replication of SARS-CoV-2, which is coronavirus disease, in vitro. Do you suggest that this paper can be generalized and that you can take the ivermectin and give it to your COVID-19 patients?
Actually, it is in vitro, like it's a preclinical, right, stage?
Yes, exactly. Great job. Great work. Layla, I think you want to say something?
Yeah, I was gonna say the same actually.
Exactly. Glad guys. Great job, guys. So yeah, this paper has been shown very good effect, but it's in vitro, guys. It's not clinical a phase. What phase it is in a clinical trial? It's a preclinical phase. It can be just the basic science research. If you remember the types of research that we've talked about before earlier at the start of this webinar, we have basic science research done in lab on lab animals and things like that. We have clinical research, which is done on people, on human beings. So this study showed a very promising result, actually, that is the drug is inhibiting the replications of SARS-CoV-2, but it's in vitro. It's not a clinical trial. It's not for humans. So you just take this results for yourself. You generate your hypothesis that done this. It's a very positive and promising result. So you start the preclinical phase and you go on with the clinical trial procedure to make sure whether ivermectin is good for it or not. But based only on this result of this paper, you cannot go from there and give the drug to individuals because it might be not safe for them. It might have several side effects. It might interact in a negative way with human body and human enzymes and hormones and things like that were not clear in vitro in your lab. So another thing is that actually when estimated the dosage that you need for this drug to show the same inhibition effect of replication of the SARS-CoV-2 when applied to humans, the dosage would be 1,700 times more than the one used in the research paper. So, for example, if they've used 1 milligram of the drug in their in vitro process, pharmacology professors and scientists say that to do the same effect in human body, you would need a 1,700 times dosage more than what I've done in this in vitro process. So, also this may be not acceptable, maybe a very large overdose for human body that can cause many side effects, and showing the inhibition of replication result, positive results that we want to see in human bodies. So not every in vitro or lab or basic science research can be applied over human and clinical research. It has to go through some specific process. Methodological processes such as the preclinical phase 1, 2, and 3 clinical trials before making sure that the dosage is okay, the side effects are good, we know the effectiveness of the drug to test it, and for humans to take it. So do we have any questions until now? Are there any questions? Okay, great. So now let's do a recap, a quick recap. We've finished. There is no new thing that we're going to talk about again. So just to recap the algorithm, let me just clear the annotations. Clear. Okay. So this is the algorithm. I want you to. I will send you, of course, this presentation. I want to memorize it very well because this will be your life when reading as a physician or as a medical student for research study projects that have been published in a very critical period like the pandemic that we're living currently now. So when we have a new study published, you have to see whether it's a preprint or a peer-reviewed. If it's a preprint, again, please make it to yourself. Do not share it until it's a peer-reviewed, published, and critically appraised, put it in guidelines, for example, and can be approved and used on humans. Second thing, if it's a peer-reviewed journal, you look at 4 main important pillars or categories. Is it controlled or not? If it's not controlled, you cannot have a good comparison to what extent is the drug effective or not. Is it randomized or not? Because if it's not randomized, you will have bias. Some of the groups may have more age or less age more than the other that may interfere with the results. The sample size, which is a very important thing. The very well calculated studies have very good sample size, will show the difference and show the accurate and specific result that you would be underpowered. If it's a very large sample size, it would be also overpowered, and both are not ethical. The sample size is what we want. And last but not least, the outcomes that you, as a researcher, as a medical student, reads the research paper, need to put in mind. Do I want clinical significance? Do I want statistical significance? Do I want specific biomedical outcomes? These are the things that you should put in consideration while reading the paper to make sure whether it's relevant to you or not. Can't find my cursor. Okay, so thank you all for joining us. I'm very sorry if we've spent a lot of time here. I know this can be intimidating when hearing for the first time, but it's crucial and very important for all of us to learn. This algorithm is great. It's been made by a friend of mine, Ashley. Me and him have been working very hard on this. We put them all together for everyone to learn. We've given this algorithm to another NMOs, for example, here in Egypt, in Palestine, and some local and national workshops here. So thanks a lot for sticking till this late hour. I think it's 7, so we spent like quite 2 hours.
Yes.
Thank you for joining us. If you have any further questions, this is my cell and WhatsApp number and emails. You can find me on Facebook under the same name, Ahmed Hassan Sherif. You can have my social media for Mika, for example, or I'm with you also in the WhatsApp group. What else again? The presentation, you will have the presentation. And I will send you a link, a Google Drive link to a various research books and textbooks that you can use to learn about study designs, to learn more about scientific writing, learn more about methodology in general. I will share that with you on WhatsApp once we are finished here with this webinar. I hope you enjoyed it. I hope you learned something today. Man, your explanation is unique. Thank you very much, Abdurrahman.
Also saying, I want to say that also thank you, Ahmed, for your great and essential information.
You're very welcome. Thank you, Mika.
Us, I think, enjoy. And Leila wrote that, can we have you for the next time again? I can say,
yeah, sure.
With Ahmed, we are thinking about for the one more event in the future, yeah?
It will be my pleasure. It will be my pleasure to join, guys.
Oh, thank you.
And thank you guys for your sweet words.
Thank you, thank you. And Ahmed, can we take a pic, please?
Yeah, yeah. Thank you for reminding me. I was gonna forget that. We would appreciate it, guys, if you open the camera.
My button does not work.
I would stop the screen sharing. Guys, I would appreciate it if you open your cameras.
Open your cams.
Thank you, Leila. Thank you, everyone. Okay, a gallery view. Awesome. Thank you, Rugia. Thank you, Leila. Thank you, Is, I think, or Easy. I'm sorry if I'm not pronouncing it right. Thank you, Muhammad. Thank you, Sila. That's awesome. Thank you, Nagor. That's awesome. Actually, let me take one with my phone, and we're going to take a screenshot.
Okay, please cheese, guys.
Awesome. 1, 2, 3. Awesome.
Okay, thank you. Thank you for your attention. Thank you for participation. Thank you for your time. Hope we will meet again. Okay.
Awesome. Thank you, guys. Thank you for joining us.
Thank you very much.
Thank you.
Really, that was very nice and awesome because, you know, sometimes the webinars are just consisting of theoretical part, but practical part really helped us a lot. Thanks for your
I'm glad you like it. I'm glad you like it. Thank you.
Really, we appreciate you as an MBS Azerbaijan family.
You're welcome. Thank you. Thank you very much. I have very much fun joining you guys. Thank you.
The same. Thank you. Bye.
Okay.
Stay
have a great
safe.
night. See you guys.
Bye.
Have a great night. See ya.
Bye. See you. Bye.